India's healthcare ecosystem is split down the middle. On one side, it operates as a global hub, drawing medical tourists to its world-class surgical theaters. On the other side, a major medical event is a domestic financial trap, pushing an estimated 40% of middle-class families below the poverty line every time they receive a major hospital bill. A primary driver of this cost explosion comes down to how the patient-physician relationship has shifted. In previous decades, care was rooted in community trust and physical examinations. Today, healthcare operates as a commercial transaction where patients view themselves as consumers paying for a guaranteed outcome. Because failure is now often met with litigation in consumer courts, modern doctors are structurally forced to practice defensive medicine. To establish a legally bulletproof paper trail, they must order exhaustive diagnostic panels and imaging, even when a clinical diagnosis is already obvious. This defensive approach shifts the operational focus from pure clinical intuition to protocol compliance and meticulous paperwork defense, adding a significant layer of diagnostic overhead to every patient invoice. These extreme financial pressures are most visible in high-complexity procedures, where interventions like lung transplants can reach costs of 60 lakhs to over 3 crores. This chart illustrates exactly how these procedures drain wealth, and the bulk of the cost isn't the surgery itself, it's the waiting period. When patients enter terminal respiratory failure, they are placed on an artificial lung system called ECMO. Operating this machine costs 2 to 3 lakhs every single day. Because finding a compatible cadaveric organ can take between 10 and 60 days, a family's savings can be depleted before the patient ever reaches the operating room. Once the transplant is complete, the toll of extended artificial life support necessitates complex, highly specialized immune recovery protocols. This adds a massive flat-rate block of surgical and post-operative costs on top of the already towering ECMO expenses. For these critical emergencies, organ availability becomes a game of financial endurance. Addressing the cost of these interventions requires systemic solutions to organ allocation and insurance, rather than just improvements in surgical technology. Dr. Bhaskar Rao, a cardiothoracic surgeon who built KIMS hospitals into a massive national network, argues that medical practitioners are the best people to solve this affordability crisis. But they can only do it if they master the ruthless mathematics of corporate scale. When clinicians try to build their own facilities, they often fail because of the gestation period. From the day a Tier 1 medical facility opens, it carries inescapable fixed operational costs, including power, medical consumables, and specialized staff, totaling 3 to 10 crores every month. Take a look at this cash flow graph. Patient volumes take 12 to 18 months to reach an operational break-even point. During that gestation period, the business takes a steep initial drop into a negative cash flow valley. Without a specific capital reserve, the hospital will collapse into bankruptcy before it treats enough patients to survive. To survive this valley, founders must follow the rule of loss funding. They have to hold exactly 25% of their total initial project capital expenditure in liquid reserve, explicitly absorbing the impact of those early months. Medical brilliance cannot effectively reach the masses unless it is anchored by a perfectly calculated financial runway. Once a hospital secures its basic survival, scaling it into a national network requires avoiding blind expansion. Instead, administrators map unmet market opportunities using strict demographic math. This data funnel visualizes exactly how capacity is calculated. Starting with the total population of a region, hospital builders know roughly 5 or 6% of people will fall ill annually. Of those, 10 to 15% require outpatient care, and a predictable fraction will need an inpatient bed for an average stay of 3 to 4 days. That funnel is just step 1. From there, the rest of the due diligence matrix locks into place, evaluating the region's per capita income and private insurance density, checking local physician talent pipelines, and rigorously clearing real estate title anomalies to avoid structural delays. Once the facility is built, retaining specialists requires a shift in management. Instead of luring doctors with predatory signing bonuses tied to commercial patient quotas, sustainable networks offer absolute clinical autonomy and institutional equity. Corporate scale in healthcare is achieved by using demographic data to build the physical infrastructure, while using physician co-ownership to protect medical ethics inside the walls. Even with perfect demographic planning, Dr. Rao noticed a massive systemic inefficiency. Look at this top-down grid representing private hospital capacity. At any given time, exactly 20% of those beds remain chronically vacant. To fix this, he proposed the Arogyasre public-private partnership. The government agrees to cover baseline variable costs, like power and consumables, for those empty beds. In return, private hospitals fill that latent capacity with below-poverty-line patients, operating at cost. To ensure the private sector actually participates, the government uses a green channel mandate to clear hospital payments within 10 days. This operational blueprint of leveraging latent private capacity proved so effective that it was scaled into a massive national welfare program, Ayushman Bharat. This strategy demonstrates that public welfare can be expanded by integrating private assets into a state-funded framework, rather than relying exclusively on new government construction. Even with high corporate efficiency and government subsidies, the final piece of the affordability puzzle relies entirely on the psychology of the middle-class consumer. The current cultural mindset often views a health insurance premium as a dead-weight expense. This creates a psychological trap where individuals feel they've wasted their money if they pay into a policy for years without falling sick. To break the cycle of medical bankruptcy, the public has to normalize health insurance as a basic, non-negotiable cost of living. A robust family policy often costs less annually than discretionary lifestyle habits like smoking or entertainment. It is a long-term investment in financial security. True healthcare reform requires 3 pillars: compassionate clinical execution, ruthless corporate loss funding, and a society that takes proactive responsibility for its own financial protection.